I'm with Karen York of Alive Hospice in Nashville. And Karen, thanks for joining us today.
You're welcome. It's my pleasure.
Thank you. And we just wanted to go through and ask you a little bit about Alive Hospice. Just maybe if you could provide us with an overview of your organization and perhaps tell us a little bit about its history, how it got started.
Okay. Alive Hospice has been in the community, in the Nashville community, for about 34 years. We started in 1974 or 75, if my math is correct.
Okay.
And with a view from a couple of the physicians in the community. One was a psychologist and one was a surgeon, who really wanted to expand. They recognized the need for hospice care of their patients and got together with some local folks, like I said, in the community to provide an interdisciplinary plan of care, which means it goes beyond physicians and nurses, but also includes like spiritual components and social work components and so forth, so that their patients could be seen at home and could have a dying experience that at that point in time really wasn't being met in the medical world.
Exactly.
So with their vision, they started in a home in one of the local communities. And it was all volunteer, and hospice in the United States was all volunteer for quite a long time. It was just people feeling the need and sending folks out to the patients in that community. So that was the vision, and that's how it started. They were talking about how to name our facility, our organization, and they were just throwing around, I guess, discussions about what they wanted it to be. And they talked about adjusting to life-limiting illness. And so as the discussion went about, as I'm to understand, they came up with that acronym, was adjusting to life-limiting illness very effectively, hence the name Alive. Yeah, it's very interesting. And it is truly representative of the type of work that we do. It really is to help people live until they die. So often in our thinking or in the medical community, it's like, okay, we'll get them to the point where there's no more cure, and then you're going to die. And they wanted to help bridge that and say, okay, how can we meet the needs of these folks where a cure is no longer possible, but still they have time to live, and how can they do that comfortably, and how can they do that
with
effectively? With dignity, right. Safety and making some closure. So it might be financial, it might be business arrangements that need to still take place. It can be spiritual, how they're connecting with their divine purpose or whatever that means to them, as well as, of course, the physical. Still making them comfortable and helping with anxiety and all those things that are really, really important during that time of life. So it's not just saying, okay, you're going to die, good luck. They wanted to give that whole idea of it's a very vibrant and can be a very beautiful time, and they wanted to be there to help facilitate that. Now,
do you refer to these folks as clients? I mean, how do you refer to the individuals that come here?
We call them patients. Our patients and our families, and it is that whole group of care, and that's another thing that makes hospice a little bit different than acute care or some other types of care. The model is different. It's about, of course, meeting the needs of the patient, and we talk about one of the goals of hospice is called self-determined life closure, meaning that they get to determine, if you will, what they want that dying experience to look like. But that also encompasses the family or the caregivers, whether it's blood relatives or whatever they consider that their family. So we meet the needs of them as well, because often they may be having a harder time dealing with this than the patient, him or herself. So, and we find that often the patients, sometimes they kind of know when they've been through, the business of whatever treatments they've been on. Let's say if it's cancer and having chemotherapy and going through all kinds of regimens, and their body's kind of telling them we're not going to take anymore. But the families sometimes often, we need to do everything we can, and so it's really helping minister to all the family as well, to kind of get to the same place if possible.
Now, how would your patients be referred to your hospice? How does all that work?
Most often it's a referral by a physician in the community or a discharge planner from a hospital that has connections, with the physician there at the facility. Any person can ask to be a hospice patient, but it does need to come from a direct order or some type of a referral from a physician.
All right.
So it may be through their family practitioner, their internist, it could be from their oncologist if they have cancer.
Sure.
It can be directly from a hospital, like I said. Sometimes they come from a hospitalist who's taking care of folks in the hospital. So.
Okay. Is this something that insurance pays for? Is this done just out of pocket? How does that all work? Or does that vary from
It
patient to
varies.
patient?
It varies. Traditionally, well, since 1983. So if you remember, hospice started in 75, so before 75, and up until 1983, there was no reimbursement system for hospice. So in 1983, Medicare recognized hospice as a medical specialty and provided funding and reimbursement for that. And we've had that support system for all this time. So, and still traditionally our largest demographic of patients is in the elder community.
All right.
So folks from 65 to whenever have Medicare automatically. So we do receive a nice Medicare benefit to take care of those folks.
All right.
Insurance companies have a lot of them also have hospice benefits and hospice plans, and they tend to follow what Medicare does. Some of them they have differences in their plans. I would recommend to any person when you have a job to check your benefits with your employer to see if they have a hospice benefit.
I'd never even thought about that.
I would recommend that, and a lot of
Okay.
people don't think about that, and it's a very important thing, because once you get to that point of life, we don't want to think about it, but once you get to that
Exactly.
point, it can be very, especially if you're not 65 yet,
Right.
it can be very important to have that hospice coverage. Like I said, our biggest demographic is over 65, but we have a very large group of folks in between the ages of 40 and 65.
Okay.
And to make that even a bigger demographic, we see patients from all ages. So from before birth to whenever, 110, however long they live. So,
Okay.
So for those that are adolescents and children, of course, they would not have Medicare most
Sure.
likely. So there are a lot of insurances that cover
Okay.
or cover parts of hospice care.
Now, is this a non-denominational organization? I mean, do you have people from different faiths come here and?
That's correct, yes.
Okay.
We're a community-based, nonprofit organization, so we're not affiliated with any corporate structure or any denomination.
Okay.
And our goal, we talked a little bit about the spiritual component of hospice care. So
Yes.
when we have chaplains, that is part of the team.
Okay.
So when you sign up for hospice, so to speak, you will be assigned, you will have the opportunity to see a nurse and a social worker, a physician, and a chaplain and a hospice aide or somebody to come in and help with those kinds of daily
But
things.
that's what I was going to ask you about. Who comprises the staff?
Right, and
How
that's the
does
main
that-
team.
Okay.
Yeah, that's the main team. The nurse, physician, social worker, chaplain, and a hospice aide.
All right.
And so I was going to say the chaplains are versed in many aspects of faith. So they don't come in and try to impose any particular
Okay.
denomination, faith, belief. They will meet the people where they are. Some are very entrenched in the church and don't necessarily want a chaplain, and even sometimes they are. But a chaplain offers more than a religious. Their role is really spiritual. It's not about religion as much as your spiritual journey in answering and helping to find answers to spiritual questions about meaning in life and so forth. So.
Well, you hear people in the dying process, Kubler-Ross and all that. And do people go through the dying process in different ways? I mean, what have you observed in your experience?
It truly is individual. There have been studies, and Kubler-Ross, as you mentioned, did come up with the stages of grieving, and there are 5 stages. From anger to denial to finally getting to acceptance. Knowing that any one of us, you don't go through all those in that cycle. It's not a perfect cycle. You can become angry and deny it at the same time, and just get angry again.
Probably kind of go back and forth.
You go back and forth, and it can hit at any time. So people do accept or not accept death differently, and the grieving process is so complicated from each individual.
Yes.
So it is a dynamic process.
How about the family? I mean, they're going through a lot of stress themselves. How do you take into account the needs of the family?
That is really part of what the whole team does. And the social worker sometimes is the person who is that person's role, really, to help with that whole dynamic.
Sure.
Because there can be some disagreements going on in the family. We walk into whatever situation that family is in, so it can be a wide spectrum of everybody agrees and everybody loves mom and dad and all the family gets along and they all have their plan in order. The social worker is still effective there, to the family who oh my gosh, this is a sudden diagnosis, and the children are little, they're leaving little children behind. Can be a family who's at odds about
Sure.
all kinds of things. They may be fighting over wills or finances, or even the care of the patient. Some
Okay.
want everything done, and some say no, it's time to let go. So the social worker with the entire team really tries to work through those dynamics and talk and listen, and tries to help get some kind of at least a semblance of some kind of agreement, and that's not always possible. It's
Yeah,
not
I
always
bet
possible.
that's got to be a challenging role, I would assume, for the social
It
worker.
really is. It really is.
What are some of the challenges, speaking of that, what are some of the challenges in working in this type of an organization?
I think the biggest challenge for us, and I don't, the internal challenges are basically economics. You know, when there are changes in the economy, how they affect us and our ability to fund and to take care of our resources and to supply the care that we need. But outside of it, our largest challenge is spreading the word and having people understand what hospice is and not being afraid of it, learning about it, making it kind of recognizing we are dying. You know, all of us are. And at some point it's going to become crucial that I engage in the hospice community, and it would really benefit me. So
Sure.
I think that's our largest challenge, both with the lay population, people like you and me, and with physicians and folks that refer to us, because we all want to live. I mean, let's
Exactly.
face it, I don't want to die.
Right.
And I don't want to die miserably. A lot of us
Sure.
say I'd rather die in my sleep or fast so I don't know what happened.
Yes.
And so, and physicians and medical folks are trained to try to cure and to make us all better and
Right.
to fix everything. And we have phenomenal technologies and operations and all kinds of things that can keep us alive and help us to live a
Right.
longer life. So it's bridging that gap with our physicians and our community to say, you know, at what point can hospice come in when you're knowing that this person has tried everything possible and it's not going to cure.
Exactly.
And helping us to bridge that transition with them. So it's an ongoing challenge and an opportunity to help folks in the community understand that we are here to partner
Sure.
with them in their lives of their patients and the journey that they're on.
What would you say is about the average length of stay, if you want to put it that way, for your patients?
Yes, that varies. Obviously, we have over, I would say probably right now around 450 patients
Wow.
total in our care. It might be a
Okay.
little bit more, a little bit less than that.
Uh-huh.
We have a couple of inpatient facilities. The one we are right now has 30 beds, and then we have two other inpatient facilities that are 16 beds each. So those are reserved for folks, or set aside for folks who are really needing an acute intervention. They may be in extreme pain crisis, and they need to come in and get some symptoms under control. Sometimes we get folks at the very last minutes or very last hours of life
Wow.
that come here. So
Okay.
our length of stay can be shorter in one of our facilities, and in the home it can vary from a few days to a year or more. So
Right.
when we look at our statistics, our average length of stay is around 50 days, maybe. If we look at our median length of stay, which is, of course, they probably know what the median is.
Sure.
It's probably around 10 or 11 days,
Okay.
which is
All
not
right.
a very long time.
No, not at all.
Not a very long time. So what we know from our research and from our experience is that the longer we're able to work with families, the better it is for them.
Sure.
And with their loved one. We'll take anybody, if they're hospice eligible, if they
Right.
meet our criteria,
Okay.
whether it's 10 minutes or 10 days or
Right.
whatever.
Okay.
But we prefer, it's really better for them if we can have them a little bit longer.
Sure. Now, we have some students in our program who are interested in going into this field. What would be some good experiences for them, either volunteer or training, education? What would you recommend for somebody who wants to go into this field?
Right. Well, there's so many opportunities in hospice, both in the clinical, if you're a hands-on caregiver, or administrative. And I'm not sure of the complexity of your students. So, but there are many opportunities that are not direct hands-on related, but
Okay.
it's all part of being a caregiver. So, if they're going to be a nurse or a social worker or a chaplain, of course, get your degrees in those areas.
Sure.
And as part of your education, volunteer at hospices. That's one of the biggest components we have are our volunteers, and I failed to mention that earlier.
All right.
That volunteers do go into patients' homes. They come into the residence. So volunteer, get into it and see what it's like and get a feel for it, and if that matches your calling and your values.
Sure.
Because it's not for everybody. I believe we all have a gift and a calling.
Yes, I agree with
to
that.
kind of go with whatever care role or whatever that fits with us. So
Right.
you may find out that it's not for you, but at least you're more aware of what hospice is about. So there are many opportunities to volunteer. Some programs offer internships, and like a social worker or some of those, you need to do an internship. So sometimes it may be an opportunity to spend some time with us
Exactly.
or another hospice. So
Right.
I would say as much exposure as they can get to this area would be great.
Well, good enough. Well, Karen, thanks so much for spending time with us today and sharing with us your knowledge and expertise regarding Alive Hospice.
You're welcome. Thank you.
you.